Namaskar and welcome and hi to everybody. So today's podcast, critical care podcast from Young India Intensivist. As you know, we call the best experts from our country for this particular podcast, and we have done around 30 of them so far. And today we have a special guest, Dr. Shrikanth Srinivasan, sir. So, sir is very well known to most of you. He's a avid teacher, avid speaker, and is seen very commonly on the teaching circuit in India. So he's chairman, Manipal Institute of Critical Care Medicine, Manipal Hospitals, Delhi. He is been awarded the Presidential Citation Award many times. He's the co-editor of the ICCM textbook for ultrasound focus, and he's also the secretary for the Indian College of Critical Care Medicine. So today's focus is going to be on nephrocritical care, something we have not really covered too well. Dr. Raj Shekhar had come some time back, and after that we have not talked about nephrocritical care. So today the focus is on nephrocritical care. So I'll just share a case vignette and then we can proceed. So guys, this is the brief case summary. 60-year-old male with poorly controlled type 2 diabetes and peripheral vascular disease is admitted to the ICU following emergency debridement of a necrotizing soft tissue infection involving his left lower limb. He presents with septic shock, hypotension requiring NORAD, high-grade fever, altered mental status, classical presentation of septic shock, and blood cultures grow Staph aureus. And broad-spectrum antibiotic, including vancomycin, is initiated. Now, over the next 24 hours, the patient develops oliguric acute kidney injury classified KDIGO Stage III with rising creatinine and fluid overload, which eventually leads to requirement of ventilation. And renal replacement therapy is initiated along with polymyxin filter to address both renal dysfunction as well as the overwhelming inflammatory response. So typical setting, there's septic shock, there is AKI, there is fluid overload, and here the focus of infection is necrotizing soft tissue infection, and we have been able to grow staph, and staph grows easily, so probably that's why we have grown staph, and he's not received any prior antibiotics. So that is the case vignette, and now we shall proceed with the expert opinion of Dr. Shrikanth sir. So, Dr. Shrikanth sir, the first question for you would be timing of RRT. So, in this patient who progressed to KDIGO Stage III with fluid overload and respiratory failure, how do you time RRT? And clinically, what is considered early versus late RRT in 2025, now I think 2026 practice?
Thank you, Dr. Tapesh, for inviting me to talk about this. And the question you asked me is, what is the current trend or practice in 2025-26 regarding starting renal replacement therapy in critically ill patients who are meeting the criteria, as in saying KDIGO Stage 3 and beyond. So that's exactly what you're asking me. So see, this practice of RRT has gone through an entire spectrum. Initially, there was a time or a phase where the people were pro for early RRT. But as of late 2025, the current thought process is no longer about a strict timing cutoff or any such thing. It's more dependent on the patient's clinical status and presence or absence of conventional or urgent indications for RRT. So it goes to say that all the major trials have been done regarding early RRT, including the AKI trial, the Start ICU trial, and the ICU trial, Start AKI trial. These people have, all these trials have proven no benefit from early RRT. What do you mean by early RRT? RRT, when as per the trial definition, is as soon as the patient reaches KDIGO Stage 3, within 6 to 12 hours of that, we start renal replacement therapy. But the meta-analysis of all these large trials have proven no benefit with regards to early RRT. So where does it put us in 2025? In 2025, we have returned back to standard and delayed RRT as the way to go forward. Now, what is standard and delayed RRT? Standard and delayed RRT will involve what is the time-tested conventional urgent indications for dialysis, which is refractory fluid overload, which is diuretic refractory pulmonary edema, refractory severe hyperkalemia with a potassium of more than 6 or 6.5, especially with ECG changes, severe and refractory metabolic acidosis, which is non-responsive to soda bicarb, so a pH less than 7.15, despite bicarbonate therapy, there we'll probably go in for RRT. And life-threatening uremic complications like uremic pericarditis, encephalopathy, severe coagulopathy, or certain dialyzable toxins, wherein these are all urgent indications. So this is what is accepted even today as one of the reasons for starting RRT. Also, what we have, the current approach is a delayed approach. Now, what do you mean by delayed? I told you what early was. Early was within 6 to 12 hours of KDIGO stage 3. Now, a delayed approach says that you can wait up to 48 to 72 hours. And it's a dynamic wait and watch period in which you look for either urgent indications to come in, or you wait to 48 to 72 hours to see the trend of how the patient is progressing. So, and if you have certain indications like oliguria or urea for 48 to 72 hours, or the BUN rises above 112, therein you can go in for RRT. So the current practice is to wait, or a delayed method in which you wait for 48 to 72 hours after the KDIGO stage 3, or whenever urgent or emergent indications occur, that time you go in for RRT. The reason which has been stated is that all these three major trials, the AKI-KI, the ideal ICU, and the START AKI, all of them have proven no benefit with early RRT. Rather, they have shown some level of harm, because RRT related complications also exist. And there have been patients who have spontaneously recovered by themselves if we have a delayed or a waitful and watchful approach. So a close dynamic monitoring would be most essential. And the practice will be to, after KDIGO stage 3, delay and wait and look at the trajectory of the disease and the worsening of symptoms before we actually go in for an RRT. So this is the current approach.
Right, sir. Thank you for the answer. Moving on now. Sir, this is about extracorporeal hemabsorption. So, is there convincing evidence to support extracorporeal hemabsorption in septic shock, especially in light of the recent TICRIS trial results?
See, I will answer
in the setting of this patient, septic shock.
Yes. So I'll answer this question in two settings. One is in a general setting, and one is with respect to this patient. So in general settings, all these extracorporeal therapies are basically adsorption therapies, right? They adsorb certain molecules, including cytokines, damage-associated molecular patterns, and pathogen-associated molecular patterns. So these are the DAMPs, the PAMs, and the cytokines are what are adsorbed by these filters. These filters can be a cytokine absorbent filter like the cytosorb, or can be something more specific like toremixin, which is specifically an endotoxin absorbent filter. Now, these modalities, even in large trials, have not proven any great mortality benefit, because that is the standard which we use for all trials, whether there is actually a mortality benefit in critically ill patient or not. So far, conclusive evidence have not been forthcoming. But having said that, there are certain positive or promising trends with regards to this trial, which will place them at the level of adjunctive therapy. So when your patient has overwhelming septic or inflammatory process, so like severe sepsis or septic shock, there you would obviously like to reduce the cytokine storm, and to some extent try to bring about some stability in the patient with respect to dose of vasopressors, with other organ failure, with improving SOFA scores. Now, coming to this patient. Now, this patient had gram-positive sepsis. So a toremixin column will be of no use. A toremixin column is basically a polymyxin immobilized column. And polymyxin immobilized is a hemabsorption column, which is going to specifically absorb endotoxin, gram-negative endotoxin. Now, this is a gram-positive issue which this patient has. So here, obviously, a toremixin will not be the greatest of help. Perhaps cytosorb is the one, the cytokine filter would be of better use to this patient. And that also as an adjunctive therapy. The primary therapy in necrotizing fasciitis will be surgery. That is the one and most important therapy. But this could be adjunctive therapy in case of overwhelming sepsis. In gram-positive patient, no endotoxin filter, that's no toremixin. In gram-positive, you can have this cytosorb, which you can use. Now, coming to specifically talking about toremixin filter, in which conditions do they actually work? So as per the recent TICRIS trial, which is a phase 3 trial, it's an extension of the previous phase 3 trial. So what they have done is they have utilized endotoxin assay that is the level of endotoxemia in the blood. So they have actually measured the endotoxin levels in the blood, and they've taken a cutoff of 0.6 to 0.9. And if they say that the endotoxin levels are above this level, that's where this polymyxin filter is shown to have definite benefit, including benefit in mortality. So they have shown a 37% mortality in this subgroup, with 45.1% mortality without the toremixin filter. So this definitely seems to be a promising trend, especially when we can prove endotoxemia, gram-negative endotoxemia, by doing an endotoxin assay. But this is still, obviously, work is still in progress, and this further has to have further larger trials to actually prove it. But that is one small subset where toremixin can be used.
Yeah. Okay, sir. Great. Now moving on to, sir, another thing which I think this is more related to the trainees, junior trainees, is the dose of CRRT. So they often ask what is meant by the dose of CRT, and then moving on further on that question, what should be the practical dose of CRT considering the downtime or the off time?
Yes. So let's talk about what is dose of CRRT. CRRT dose means the volume of blood which is purified of the waste per hour. So this is the generic definition of dose of CRRT. But how do we measure it practically? We measure it by the effluent dose. So in CRRT machine, we have got what's called the effluent dose. So the effluent dose is the measure of the CRRT dose. Now the effluent dose depends upon which modality you have chosen. We have three different modalities: CVVH, CVVHD, and CVVHDF. In CVVH, the effluent dose is a combination of the replacement fluid and the ultrafiltrate. In CVVHD, it is dialysate fluid, ultrafiltrate. And CVVHDF, it is dialysate plus replacement plus ultrafiltrate. Now, what is the dose which is prescribed? Okay, so there is two types of doses. One is what is prescribed dose and what is delivered dose. So we should understand the difference between both and how it is important to us. The current KDIGO guidelines suggests a high intensity dosing. That is around, it's around 25 to 30 ml per kg per hour. Beyond 35 ml per kg per hour, which is called higher intensity, that is not prescribed or not advised. Why? Because it ends up clearing off all your antibiotics, your corticosteroids, washing them all out. So that may not be very beneficial, and even large trials have not shown any benefit with high dose of CRRT. So the dose which we are trying to target is around 25 to 30 ml per kg per hour. But how do we reach that? So the practical calculation is that we are considering that the CRRT machine is going to have some downtime. Downtime is wherever there's interruptions in the CRRT. Interruptions can be that the CRRT machine may stop for some time. You may actually shift the patient for some scanning or something. So if you are going to target a dose of say 25 ml per kg per hour for 24 hours, if you have these breaks, and instead of 24 hours, your machine only runs for say 18 hours. So your CRRT dose, which is calculated for 24 hours, comes from 25 ml per kg per hour and reduces to something like 17 or 18 ml per kg per hour. So effectively, we are not achieving what our prescribed dose is. So how do we correct it? We correct it by prescribing a higher dose of CRRT. And that higher dose of CRRT is around 30 ml per kg per hour. This 30 ml per kg per hour will also try to cover for what's called the dilution factor. Now, dilution factor, or what do? We have a ability to keep the replacement fluid as pre-pump, right? The pre-pump replacement fluid, what it means that it dilutes your blood before it enters the pump. So effectively, the clearance of your waste products is reduced. It becomes inefficient. So this pre-dilution factor can be corrected by assuming that, by a rule of thumb, that 15 to 20% of my of the amount of effluent is actually going waste. So if you want to correct for the 15 to 20%, you will have to target a higher effluent dose from 25 ml per kg per hour. So you would target something like 30 ml per kg per hour. So this is how we calculate as 30 ml per kg per hour. And how do we know whether we have reached 30 ml per kg per hour? We have historically, the CRRT machine gives you how much exact amount of effluent it has removed per hour. It gives you in the form of history. So after 24 hours, you should calculate the total amount of fluid has been removed as the effluent dose and what ml per kg per hour it actually falls into. If it is falling below 25, then obviously you have to further increase the dose so that you reach your target, right? So this is how we go about it. So now let me, for the trainees, let me try to give you an example. For example, if a patient is, say, 80 kilos, okay, and we want to give 25 ml per kg per hour, right? So when we say 25 ml per kg per hour and an 80 kilo person, we want to give it over 24 hours, right? So it roughly comes to around 2560, considering 20% loss. Now, how do we calculate the loss? It's 1 upon 1 minus loss. So we say 20% loss is 1 upon 0.8. So 25 ml per kg per hour divided by 0.8. So this calculation comes to around 31.25 ml per kg per hour. So this is how we calculate. So once we do by 31.25 ml per kg per hour, or we say 32 ml per kg per hour, this comes to around 2560 ml. Now this 2560 ml has to be divided based upon what modality you have, whether you have CVV HDF. Suppose I'm taking CVV HDF. So you will divide it as, first of all, pre-blood pump, which we keep around 100 ml. Say 100 ml out of 2560 is 2460. 100 ml UF, that makes it 2360. Now, this 2360 is equally divided between dialysate and replacement. So this is how your prescription goes, and that's how you set it. So 100 ml pre-blood pump, UF, whatever it is, out of the total which you have calculated, and the rest of it you divide equally between dialysate and replacement. So this is how you actually calculate the dose of CRRT for the students.
Very nice, sir. Very nice. I think that is very clear. So I think the students can go through it again. I will put up the video. Now, moving on to a little bit about antibiotics. So this patient has necrotizing soft tissue infections, serious enough to cause septic shock, and we have grown staph. So and staph could be MSSA, MRSA, we don't have the sensitivity. So what recommendations are there in terms of antibiotics for the staph causing necrotizing soft tissue infection, considering, of course, that it could be MRSA or MSSA also?
Yes. So again, coming back to the very same patient, the cornerstone of necrotizing fasciitis, irrespective of the pathogen, is emergent surgical debridement. Time is essence and time is life here. More than 6 hours delay is invariably associated with higher multi-organ failure and mortality. Now, antibiotics are essential, but they are not a substitute for surgical debridement. So let's make those things very, very clear. Urgent surgical debridement is the cornerstone without which the patient will not survive. Antibiotics is an adjunct. But what are those antibiotics? So let's talk about the broad coverage for any patient with necrotizing fasciitis. So this was Staph aureus, but I'll still tell you the broad coverage. The broad coverage will first include an MRSA cover, which is vancomycin or linezolid or daptomycin or teicoplanin, whichever you may decide, plus a gram-negative and anaerobic cover, which could be piptaz or a carbapenem, right? Plus metrogel. So this is the three things which you give prescribed upfront. So vancomycin, or some glycopeptide, similarly, a BL-BLI combination or a carbapenem, plus metrogel. This is the three combination drugs you give in all necrotizing fasciitis before you have a identification. Now, suppose you have an identification as Staph aureus, as in this case, then you will immediately de-escalate. So de-escalate to a definitive therapy, not continuously give piptaz and metronidazole, when you don't need to give in these cases. So you'll de-escalate to the gram-positive cover. Now, coming to gram-positive cover, which is the preferred gram-positive cover, will depend upon whether it's MRSA or MSSA. Now, if it's MRSA, let's talk about MSSA first. The MSSA, the beta-lactams are superior to glycopeptides like vancomycin. So beta-lactams here will be either nafacillin or oxacillin or cefazolin. So nafacillin and oxacillin, the doses are much more frequent. It's 2 grams every 4th hour. Cefazolin is 2 grams every 8th hour. It's much more easier to give. But the problem with cefazolin is that it is for milder infection. For heavier infection, you may have what's called the inoculum effect. Inoculum effect says that, what does it mean? Is that when you have a very, very heavy growth of bacteria, then your MICs automatically go high. So antibiotics like cefazolin may be useful for lesser intensity, but not for high intensity inoculum growth, for deeper infections or for very foul infections where nafacillin and oxacillin will be a good idea. This is MSSA. Now, MRSA, there the dose preferred agent is vancomycin or daptomycin or linezolid. Even teicoplanin can be used, at least in India we can use it. The dose is classically vancomycin is 15 milligram per kg every 12th hourly. And the trough dose, which we target, is around 15 to 20 microgram per ml, especially for severe infection. Daptomycin is 8 to 10 ml per kg IV daily, and linezolid, we all know, 600 milligrams 12th hourly. Now, the question is whether we should add clindamycin in this entire picture. Now, clindamycin, why is it attached? It is attached both for MRSA and MSSA, number one. It is used as a toxin suppressor because it has the ability to inhibit ribosomal protein synthesis of bacteria, and this blocks the production of virulent factors like toxic shock syndrome 1, TSST1, and the PVL gene, the Panton Valentine leukocidin gene, which is extremely the most dangerous form of the bacteria. So it blocks the production of these two toxins and hereby acts as an antitoxin effect. So the combination would be naphacillin, oxacillin plus clindamycin for MSSA, vancomycin, daptomycin, linezolid plus clindamycin for your MRSA. And obviously, surgery is the most important thing. And urgent surgery, less than 6 hours, is the most major factor for survival.
Right, sir. Wonderful. So I think that was very clear about antibiotics. And now moving on to again CRT. So the patient starts improving and starts pouring out urine. The creatinine starts falling, sir, and septic shock starts resolving. So we have to decide about stopping the CRT. So how do we decide about stopping the CRT?
Okay. So the thing about CRRT, when we have to stop, is first and foremost that we have to consider that the patient has sort of started reversing the factors which has caused the AKI in the first place. So first is marker, obviously, is a sustained urine output. So once you start having a spontaneous diuresis, then you start thinking that the CRRT, at least 400 to 500 ml, more than that per day, or 100 to 150 ml in a 6 to 8 hour period. Then what we do is we stop the CRRT for some time, or hold for some time. We make the ultrafiltrate as 0. Initially, we might be removing around 100 ml, now we make it 0. And we see how the fluid goes over the next 6 to 12 hours. Along with this, we need to have stable electrolytes and acid-base status. Obviously, there should be no breakthrough hyperkalemia, no breakthrough acidosis. The bicarb should be more or less acceptable. And third thing is that there should be a spontaneous reduction in the uremic toxins also in the form of urea and creatinine clearance. Maybe there may be a slight rise initially. At some stage, they should plateau and start to dip down. This will set the nidus for trying to trend down the CRRT. At the same time, we need to see that the patient is hemodynamically stable, because a patient whose vasopressor is increasing at some stage and is still not resolved, there stopping the CRRT will not really help, because it was important to maintain the fluid balance in this patient. And if he's able to manage his volume and nutrition, also we are able to deliver without actually overloading the patient, that's the time when we stop and discontinue the CRRT. So we'll stop and hold when he starts having all these above factors, and then we observe for 6 to 12 hours, and then we can discontinue. Now, what about those conditions where the patient only has uremia and otherwise producing good urine? So this happens very often because first the diuresis starts, later on the clearance starts. So here we can stop the CRRT and go on to an intermittent modality just to reduce the load of the urea and creatinine if it is deemed necessary. Otherwise, we can wait for spontaneous recovery of the kidney. But if it is deemed necessary, the patient becoming dull because of uremia, then we can do intermittent therapies instead of doing a continuous modality. Does that answer the question, Dr.?
Yes, absolutely. Thank you, sir. So moving on to another question is about, so this is a clinical question. Now he had diabetes, and diabetes patients often, they have diabetic nephropathy and underlying CKD. And many a times we don't have baseline creatinine, right? We don't know the history and all. So is it possible to somehow find out whether this is just AKI or AKI on CKD?
Yes, this is it's a constant vexing question where it's sometimes hard to differentiate when the patient has no baseline creatinine value, whether it was an AKI on CKD, or just it's one of those spectrums. So when you don't have a baseline creatinine, unfortunately, all our classification is based on creatinine levels. So if the criteria is up to 7 days, it is called AKI. Between 7 days to 3 months, it is called acute kidney disease. After 3 months, it's called chronic kidney disease. This is the definition spectrum which goes on. So if you don't have the creatine values, then you will have to rely on historical data. You'll have to rely on the physical examination, the image, and the laboratory examination. So prior medical history, if it is supportive, for example, the patient long-standing diabetes, as this patient had, long-standing diabetes, hypertension, heart failure, recurrent UTI, these are all risk factors for having some level of renal dysfunction, probably some level of CKD, which is already going on. So these patients probably have acute on CKD rather than actually having de novo AKI. Second hint which you may have, if the patient is chronically anemic. So anemia of chronic disease, that pattern if these patients have, because especially normocytic normochromic kind of anemia with low erythropoietin levels. So this also suggests that the patient probably has a pre-existing kidney disease. Secondary hyperparathyroidism, elevated parathormone levels with a high phosphate and low calcium. These things take time to come. So in AKI, they don't appear right off all of a sudden. Off the bat, if you have a high phosphorus, it doesn't appear in AKI all of a sudden. A high phosphorus by itself should sort of tell you that this patient probably has some chronicity in the background. And uremic symptoms, if they have encephalopathy, uremic pericarditis, all these things take time to come. Coming to the lab investigation, on an ultrasound, you can, if you find a small kidney less than 9 centimeters, which appears bright. What do you mean by bright? More ecogenic. More ecogenic in the sense because more fibrotic and small and shrunken. So this kidney is a diseased kidney with loss of corticomedullary differentiation. So the kidney appears bright as the hilum. Now, there are some pitfalls to this kind of definition. So because diabetic nephropathy may have a normally sized kidney. Patient with polycystic kidneys, amyloidosis may have normal sized kidney, but still they may not have any function. Then a urea creatinine ratio also may help. A high urea creatinine ratio, more than 20:1, may say it is a pre-renal AKI. A really normal urea creatinine ratio or 10:1 or something says that something it's either renal or post-renal. So that also gives you a hint that probably this is a pre-existing disease as compared to what an acute kidney injury might have been. But mind you, there are significant overlaps. So that obviously the time will tell what exactly it is. So these are a few factors which may point towards a chronicity.
Yes, absolutely, sir.
And in our patient,
these are the points, absolutely. So that, well, one should always look for CKD because the entire scenario changes if the patient has CKD, and these are the points. So thank you, Dr. Shrikanth, sir. It's been around 25 minutes and we have finished the session. Thank you very much for joining us, sharing your experience, and talking to everybody. I'm sure this will be of great benefit to everybody, and we shall put it up on the channel soon. Thank you very much. Good night. And I thank the viewers for joining in. Thank you very much. Bye-bye. Good night.
Good night. Good night.